Okay, blood vessels. Not that difficult with their anatomy, but extremely important when we start thinking about the physiology of blood vessels. But let's start with the anatomy first. On the board, you're seeing a typical capillary bed. There are three different types of capillary beds that I'll teach you today, and they have mm, three different types, three different abundancies of each one. There's one that's more abundant, one that's not as abundant, but they do have similar characteristics. It is not a very lengthy lecture, which is why I put this lecture today before your lab exam so that you would have time to collect your thoughts and decompress. Yesterday, we established that arteries carry blood away from the heart. And from an artery, we now need to start to learn the different types of arteries. They have different anatomy. There are elastic arteries and muscular arteries. From there, we lead to an arterial, which is the smallest of all arteries. From arterioles, it leads to a branch called a metarterial. And from that, we lead into a capillary bed, like I showed you on the very first slide. Capillary beds are the smallest of all vessels. Did anyone pick up on the difference of what I just said? What's the smallest of all arteries versus the smallest of all vessels? See, probably at this point, because you're thinking about lab, and you probably did not pick up on that difference. Arterioles are the smallest of all arteries. Capillaries are the smallest out of all of the blood vessels. From a capillary, we will see that there is a thoroughfare channel. I'll explain what the function of that is. And we'll also learn about these bands called precapillary sphincters. And then after that, we have a venule. And after that, we have a larger vein. And after that, we then have the vena cava. The two different types of arteries are elastic. Those are the ones closest to the heart. Most notably, aorta, coming off the left ventricle, and the pulmonary trunk, coming off the right ventricle. They have similarities. The similarities are that they have three tunics. A tunic means a layer, 3 layers. Going from external to internal, going from the outside of a blood vessel to the inside towards the lumen, we have the tunica adventitia, also known as the tunica externa. It is made of collagen fibers. Deeper to that, we have the tunica media. Think M for media, and M for middle, and M for muscle. It is made up of smooth muscle, which I'll remind you is spindle-shaped, mononucleated, non-striated, and involuntary. The most internal layer is the tunica intima. And I want you to think of intima sounding very similar to the word intimate. And I want you to think of that layer being very intimate with the blood inside that's flowing through the vessel. The tunica intima is made up of simple squamous endothelium. It is roughly basically similar to simple squamous epithelium, but because it's in a blood vessel, it came from a different embryonic origin, so we call it endothelium to recognize that. So they have these tunics. Both types of arteries share those qualities. So elastic arteries, like I said, are the arteries closest to the heart, most notably the pulmonary trunk and the ascending aorta. These vessels are the first vessels to receive the entire ejected blood volume. The amount of blood ejected from each ventricle is called stroke volume. A typical stroke volume is 70 milliliters for every beat the heart makes. That's typical. So these first vessels, these first arteries coming off of the heart, have to be able to withstand, accommodate very high pressures when the ventricles contract, and the entire bolus, the entire stroke volume of blood. They must need great elastic properties. And in fact, in your lab exam, you best be ready for elastic tissue, which is different from elastic cartilage. How? They both have elastic fibers, but how do you distinguish the two? Did you want to take a guess?
I think elastic tissue is more stringy, and then
Wavy.
cartilage has white spaces.
The lacunae. So there are cells, large cells in large lacunae. Exactly. It sort of looks like a whole bunch of owl eyes, doesn't it? You don't see anything like that in elastic tissue, do you? No, no. So the two tissues are similar in that they have similar elastic fibers. And that's why they stain, they have to use a different stain to identify those fibers. That's why they both look dark and kind of creepy, but in elastic tissue, we don't see those owl eyes that we think of. So elastic arteries, being closest to the heart, need great distensibility. They must be able to stretch. But when the heart is at rest, with all this elastic tissue, there is a great recoil. And we've talked about the most important property of elastic tissue is not so much that it can stretch, but it's also the recoil that we're most concerned about. So when the heart is at rest and these large vessels recoil, because a rubber band can't be stretched on its own, but it can recoil on its own. This applies pressure on the blood inside and propels the blood further down the vasculature. So even while the heart is at rest, your blood is still flowing. Elastic arteries have elastic threads in the tunica media, sort of feathered between the smooth muscle, That was on a slide that you should know. Muscular arteries, it makes students think that they're leading to only skeletal muscle. That is not true. Muscular arteries, I think, should be called organ arteries. They're the branches that are coming off of the elastic arteries that are going to go to the head or to the arm, the biceps brachii, or to your liver, to your stomach, to your pancreas. They're going towards organs. They're the first branches off an elastic artery. They also have great elastic properties, but their elastin tissue is organized in a different way. They are not interspersed between the tunica media smooth muscle cells. Rather, they are arranged in a sheet. And another word for sheet is lamina. So we have the tunica intima made of simple squamous endothelium. Between that and the tunica media, we have the internal elastic lamina, internal elastic sheet. Then we have the tunica media, and between that and the tunica externa or adventitia, we have an external elastic lamina. The elastic laminas here are shown in yellow. Now, the smallest of all arteries are called arterioles. And arterioles are known as the resistance vessels. And the reason why they're called that is because even for their size, being so small, they actually have a thick ratio of tunica media, the smooth muscle, compared to their overall diameter. So let's think about proportions. What is a proportion? It's a division problem, isn't it? You have a numerator and you have a denominator. So if the numerator was the thickness of the tunica media and the denominator was the diameter of the entire blood vessel, arterioles being so small, that denominator would be a small number, but the thickness of their tunica media is proportionally thicker, so that would give us a bigger number. If you divide a small number into a big number, you get probably a whole number or close to a whole number, don't you? But all the other arteries, the elastic and the muscular, if you take their diameter, they are large vessels, and divide that into the thickness of their tunica media, you would get a smaller outcome, a fraction. So they are considered, in my mind, to be the vice grip of all the arteries. They can really put the squeeze on blood in moments when you need a higher blood pressure. When would you need a higher blood pressure? When you're running for your life, during a fight or flight response. When you go to the gym, that is a mild fight or flight response, and I can prove it to you right now. Right now. I will give you an A on every exam for the rest of this semester if you can run a 7-minute mile. Let's go get our tennis shoes. Did you feel your heart rate start to go up? Yeah, of course I'm not going to do that. So the idea is when you start thinking about going to the gym and getting your Tenny-Go Fasters, that's what tennis shoes are. They're Tenny-Go Fasters. That's a well-known established fact, is it not? Tenny-Go Factors? Tenny-Go Fasters. No? You've never heard of that? Do you remember getting new tennis shoes when you were little? You do? I do too. And I was so happy to have them, and when my dad would come home, I'd meet him outside and I'd say, "Dad, I got new tennis shoes." And he would always say, "Show me how fast you can run in them." Because it's a well-established fact that new tennis shoes let you run faster. Hence, Tenny-Go Fasters. Feel free to use that in the future. So even thinking about putting on your exercise clothes makes your heart rate go up and your blood pressure. It's as if your body is priming itself for an extra workload, for extra activity. In physics, in science, we would call that priming a pump. You have to prime a pump. You have to get the fluid going before it is going to be effective as a pump. So arterioles, they have all 3 layers. They have a tunica intima, they have a tunica media, and they have a tunica externa. They are going to branch off into metarterioles, and these metarterioles can shunt blood to different capillary beds. Histologically, this one up here should look pretty familiar to you, even though it's in pink. The slide that we have upstairs in the lab has a more of a dark color staining to it, but that's an elastic artery. Down here we have a muscular artery. Here's the tunica intima. It looks wavy. Then this dark pink band around is the internal elastic lamina. Then this thicker part here is the tunica media. And then we have this dark pink band going around that. That's the external elastic lamina. And then out here we have the connective tissue called the tunica externa or tunica adventitia. It has two names. Down at the very bottom, we see an arteriole. Here's the tunica intima, and here is the thickness of the tunica media, and then lastly we have the tunica adventitia. Here is the arteriole. Here is the metarteriole leading to a capillary bed. These bands of smooth muscle that are coiling around, they kind of look like slugs. Those are called precapillary sphincters. You have about 10 billion roughly, I think that's the number I have. Over a billion. Okay, there we go. We'll just stick to over a billion. You have over a billion capillary beds. At any given time, you do not want all of them to be perfused with blood, meaning blood going through them. If they were all perfused with blood, you would lose blood pressure very quickly and you would not be able to keep circulating your blood. This is exactly what happens in anaphylactic shock. All the blood vessels relax, the blood pools in the capillary bed, and the person no longer has adequate blood pressure to push the blood around the body. So to prevent that from happening under normal circumstances, at any given time, your capillary beds take turns. Sometimes they shunt the blood through a thoroughfare channel straight back to a venule. Other times, they don't shunt the blood using these precapillary sphincters, and then the entire capillary bed can be engorged with blood, perfused with blood. When the capillary bed is perfused with blood, this is where we can have gas exchange. The blood drops off oxygen, picks up CO2 from the tissue cells, drops off nutrients like glucose, lipids, amino acids, and picks up waste products like lactic acid, carbon dioxide, hydrogen ions, acids. So these are called the exchange vessels, because we have swapping of substances and gases. They do have cells that surround them and stabilize them, and those are called pericytes. All the cells, the tissue beds, I should say, of your body need to be a very short distance away, not a great distance away, because this process of swapping relies mostly on diffusion. So if you want effective diffusion rates, the cells must be close to a capillary bed, which is the reason why you have so many capillary beds. Which tissue type that you are going to be tested on today is avascular? It is cartilage. All three types are avascular. Which cartilage type is the most abundant in your body? Hi, Ellie. Good job. That's your bonus questions. There are 3 different types of capillaries. From most numerous to least abundant, it is continuous, fenestrated, and least abundant would be the sinusoids. If I need to tell you about their permeability, from least permeable to most permeable, least permeable would be continuous, middle, fenestrated, and the most permeable are the sinusoids. Continuous capillary beds are called that because the endothelial cells are interlocking. There are no gaps through the cell membrane. There's only gaps called intracellular clefts that are in between the endothelial cells. To me, it looks like paver stones. Here is a red blood cell known as an erythrocyte going through a capillary bed. Did you know that capillary beds, their diameter is actually smaller than a red blood cell? Red blood cells fold over on themselves to shimmy their way through the capillary bed. Fenestrated capillary beds, we see that there are holes through the membrane of the endothelial cells called fenestrations. This type of capillary bed is found in places most notably like the kidney. When we get to our renal section, you will learn about a very special capillary bed called a glomerulus. It is not the only place where we find fenestrated capillaries, but that's going to be our biggest focus. Over here, we see a sinusoid capillary bed. Large holes in the cell membranes, large fenestrations. But also the basement membrane, the connective tissue, has big gaps. It's not complete. It's not all like one continuous sheet. And what I want you to imagine is cells, white blood cells in particular, hovering over these gaps, and also cells called hepatocytes. We see this type of capillary bed most notably, but not the only place, in the liver. And all of these large openings allow the hepatocytes, the liver cells, to do their job. And their job is to detoxify your blood that just came from your intestinal tract. Everything in your abdominal cavity needs to be cleansed by the liver before going back to the heart. That means the hepatocytes need easy access to remove those toxins. It also means that there's better access for a type of white blood cell to have easy access to remove cellular debris, and those cells are called macrophages. You will learn more about macrophages in this lecture unit, but not today. So the blood-brain barrier does not allow great permeability like these capillary beds. There is another layer. So think of a continuous capillary bed in your brain. In addition to the basement membrane, there's another cell, a glial cell, that wraps around the entire capillary, multiple glial cells called astrocytes. And they form the blood-brain barrier. It is another cell acting like an insulator. This is the reason why a lot of things cannot get into your brain across the blood-brain barrier. Some things can, like anything that is hydrophobic. anything that can get through a cell membrane on its own. Aspirin is one, and also alcohol, which is why if you drink alcohol on an empty stomach in particular, all it takes is about 20 minutes, because the alcohol can actually be absorbed across your stomach lining. Most things cannot. Enters your bloodstream and then can get into your brain again within 20 minutes. 20 minutes. So it will hit you hard, and if you're still nursing that drink, or you finished it and then you order another one because you don't feel anything, do you understand? There's a little bit of a time delay. Who knew in this class I would teach you how to drink alcohol? In my t-shirt, I'll be fired before I'm retired. Veins. Characteristics of veins. The typical vein has all three tunics, again, but a very thin tunica media, very thin. Veins are considered to be your capacitance vessels. And the reason for that is because they can keep distending, like a very well-stretched air balloon that you're blowing air into, and it just inflates with no resistance. It doesn't make your cheeks sore from you huffing and puffing into it. They have a tunica adventitia, tunica media, tunica intima, but they also have something else, a valve. And these valves allow one-way directional movement of blood back toward the heart. It doesn't matter if it's valves and veins in your leg or your arm, it's one-way directional movement. These valves can fail, and the blood would fall inferiorly to a lower level, leading to bulging veins, hence the capacitance. They can keep on stretching and store blood, and that leads to varicose veins. Roughly 70% of your blood supply at any given moment is found in your veins. It is acting like a reserve, a reservoir. When you need more blood to return to the heart for a greater stroke volume, like when you're preparing to go and exercise, these veins with their tunica media can put more of a squeeze on the blood inside, pushing more blood back toward the heart. The valves prevent regurgitation, backwards flow of the blood. Veins themselves are not a really good pusher of the blood, if you will. Their tunica media, like I said, is pretty thin. But how do we actually push blood up from one lower region of our body to a higher region? Whenever we move and our skeletal muscle contracts, it's pushing on the blood inside veins and pushes it up to the next level, to the next valve. When you relax, the blood will want to regurgitate, but the valves prevent that from happening. If you remember from yesterday, cusp-like valves for the semilunar valves, the valves and veins are also like that. Anastomoses and anastomosis, singular, anastomoses, plural, are considered to be blood vessels for blood vessels. Sorry, nope, strike that, wrong. Anastomoses are redundant blood vessels to serve a very important structure. I'll come back to that. Vasa vasorium, that is blood vessels for blood vessels. Why? Let's start with that one. There are some blood vessels that are very thick, very large, like the aorta, pulmonary trunk, superior and inferior vena cava. We forget that those vessels have cells. We forget that. And we forget that they need nutrition and gas exchange too. So there are blood vessels that can branch off, large blood vessels, and loop around and come from the external portion to deliver oxygen and nutrients and pick up waste products. Vasa vasorum, vessels for blood vessels. Now, in anastomosis is sort of, in my mind, I think of like a traffic circle. Have you ever driven through a traffic circle? You have to enter, and then you can go pretty much 3/4 of the way around, and there's some other road that branches off from that. Sedona has a lot of those. I don't know if you've ever been to Sedona, but it seems like every intersection is a traffic circle. You get really good at them. You have anastomoses to serve structures that are so important that if there was an occlusion in the blood supply, that would not be for your well-being. You have an anastomosis around your femur, two arteries that connect with each other to give an alternative route. You have anastomoses that lead up into your brain, underneath your brain. It is a huge traffic circle with all sorts of redundancy. It is the circle of Willis, correct. You also have anastomoses when, if you remember from yesterday, the anterior interventricular artery and the posterior interventricular artery around the apex. In many people, there is an anastomosis where they connect. Not everyone has that, but in some people there are. Blood vessels are innervated except for capillaries. Capillaries are not innervated. The innervation primarily comes from the sympathetic division, one of the autonomic divisions that I started to tell you about yesterday. It is part of your fight or flight response. If you are running for your life, you want more blood to return to your heart so that it can pump it to tissues of your body that are suddenly hyper metabolically active. You are running. You want good blood supply to your skeletal muscle, your leg muscles. You need that. So during times of stress, your blood pressure goes up. This puts more pressure in the blood inside and makes the blood travel back to, through, and out of the heart and to the other tissues of the body more quickly. All vessels have a blood pressure. All of them have a blood pressure. And this is where I'm going to use Nana's water bottle. Now, I have a sister, Shanna. Do you say your name Nana or like Nana, like Dana? No. Nana. Okay, so like my sister, Shanna. Okay, that'll help. Water moves. Water moves for one of two reasons, and blood is mostly water. So think of blood, plasma also moving. When we go to the doctor and they take your blood pressure, they are measuring the pressure of blood pushing out on the blood vessel. It is a push. We call that hydrostatic pressure. When my boys were younger, on April Fool's Day, every April Fool's Day, I would get a water bottle and I would say to them, "Come here, I'm going to show you something. I'm going to make the water shoot out of this bottle without tipping it over. I'm going to make the water come out." And they'd say, "Really?" I mean, they were little. I'd say, "Yeah, get real close." What was I going to do? That's a pressure. I'm pushing on the water inside. It's pushing back on the container. That's why your water will assume the form of the container it's in. It's pushing on it. If I were to put a hole in Nana's bottle, what would happen? Would the water stay there? It would come out because it's pushing out. It's a push. Now, the other reason why water will flow is for osmotic reasons. We talked about that a little bit in my lecture on cells and tonicity. That's a pulling. That's a pull. So water is either pushed or pulled across membranes like cells, that would be osmosis, or pushed through your vasculature, that would be hydrostatic pressure. All blood vessels have a hydrostatic pressure. That is what we're measuring when we take someone's blood pressure, the pushing pressure. That is what we do all the time when we take someone's vitals. So speaking of blood pressure, how many of you know how to take someone's blood pressure? Using the auscultatory method, meaning with a stethoscope. Do? Briefly describe it to me. What do you do? It's okay.
You have to check where the pulse is right there, and then you cuff it according to how the blood pressure cuff says, and then you inflate it to 40, I believe, and then you have 20 more, so 160, and then you listen. Well, first you listen to see that it's there, and then you blood pressure cuff, inflate it, and then once you hear.
So I'm going to help you out.
I was close.
No, you're very close.
So you tighten you glue the blood vessel with the blood pressure cuff to stop the blood flow, and then you slowly release pressure.
That's
and,
true.
And the point where the blood actually goes through, that's Korsakoff's sound or something like that?
Korsakoff's.
Yeah, that's where you get your systolic. And you keep lowering down the pressure until you lose the sound, and that's your diastolic.
Correct. So let me do it again. This graph, this picture, best shows what Brian just described. And Sylvia?
Yeah.
Okay. So here's your cuff pressure. It's higher than your blood pressure shown here. And your blood pressure is pulsatile. When the heart contracts, blood pressure goes up. That's systolic pressure. When your heart relaxes, the pressure goes down, diastolic pressure. So you inflate the cuff pressure around the brachial artery, and when the cuff pressure is higher than your blood pressure, you have occluded the brachial artery. No blood can flow through it. No flow does not generate a sound. Do you remember yesterday's conversation about what generates sound? Turbulent. Good. Success. So no flow, no sound. As you deflate the cuff, and that cuff pressure, the moment it is lower than the highest of the blood pressure values, systolic pressure, you start to hear turbulent flow. That is what we call the Korsakoff sounds. And there are different types of them. There's the thumping, there's the murmuring, there's the muffling. I don't have the ear for that. I only hear a sound and then I don't hear a sound. But you can actually gauge them. I think you have to be a musician to actually, because muffling to me, muffling is the sound that my kids would make when they were little and I'd put a pillow over their face. That's muffling. But there are different rankings of the intensity of the sound. So when you hear the sound, that's turbulent flow. Why? Because the space is just open a little bit. And when the heart contracts, it's enough pressure to send that blood through. That's when you look at the dial. And that's systolic pressure. The cuff continues to deflate. And the blood goes back to laminar flow. Does laminar flow have sound? No. So as Brian said, when you lose the sound, that's when you look at the dial again, and that will give you diastolic pressure. That's basically how we take the auscultatory method of blood pressure. There's also palpatory methods, and I hope you learned that in physiology. Why do we take blood pressure from the left arm? Traditionally. You're right.
Oh, that's closest to the skin.
Closest to the heart. Could we take it from the right arm? We can. Would it be slightly lower? Okay. Can we take it from around the thigh? We can take it from legs, can't we? In theory, could we put the cuff around someone's neck and inflate the cuff and take blood? In theory.
No.
Should we? No. Okay, so there's a difference. In theory, kind of. But do you know how it was discovered, about who discovered blood pressure or worked with it, documented it? A physiologist named Stephen Hales. And the way he did these experiments on blood pressure, now think about this. There are old pictures of him, and he is inserting a cannula, a large needle, into a horse's common carotid. And you see another man trying to keep the horse calm, this large needle going into their neck. And Stephen Hales is standing up with this column of mercury and tubing that is anchoring that cannula, that needle, to this column of mercury. And every time the horse's heart contracted, it pushed the column of mercury up higher. Every time the horse's heart was relaxed, the column of mercury dropped. And that is the reason why, to this day, when we give blood pressure values, it's in the units of millimeters of mercury for that column going up or down, millimeters of mercury. Now, that's a very invasive way to take blood pressure, isn't it? Aren't you glad we don't do that anymore? Would you go to the doctor knowing the first thing that they're going to insert a cannula into your neck to take your blood pressure? I would not. But that was Stephen Hales. All vessels have a blood pressure. All of them do. All of them. The blood pressure drops the most across the arterioles. Why? They're the resistance vessels. They can really put a pressure on the pulsatile pressure, making them less pulsatile, and that will ensure that the little capillary beds that only have endothelium, a basement membrane, and some pericytes don't get shredded to bits. Which vessel has the lowest blood pressure, do you think? Even the pulmonary circuit, shown here. There's blood pressures going from the pulmonary trunk to the pulmonary arteries, to muscular arteries going to the lungs, to arterioles and capillary beds, back through venules and veins, back through the paired pulmonary veins to the left atrium. All vessels have it, whether it be systemic circuit or pulmonary circuit. But which vessels have the lowest pressure? And before you answer that, how does blood flow? I demonstrated it yesterday. I kept saying it over and over again. From high to low, high pressure to low, which means, and listen to me on this, because I guarantee you in physiology, you're going to hear my voice right now, and you're going to say, hello, Kara spent a lot of time on this, so here we go. If you want blood to flow from the ventricle, let's just pick the left side of the heart. Left ventricle into the aorta. The ventricle must generate a greater pressure than the blood that's already there in the aorta from the previous beat. If you want blood to flow from the aorta, an elastic artery, into a muscular artery, the muscular artery must have a lower pressure. If you want blood to flow from a muscular artery to an arterial, then the arterial has to have a lower pressure than the muscular artery. If you want blood to flow from the arterial into a capillary bed, the capillary bed must have a lower pressure. Blood only flows from high to low, and that even means from one vessel type to the next. You want blood to return to the heart from the capillary bed to the venule has to have a lower pressure. Blood flow from the venule to a larger vein, the vein has to have a lower pressure. From the vein to the vena cava, then they must have a lower pressure. So it's the vena cava that have the lowest blood pressure out of the whole circuit. And if you want blood to flow from the vena cava into the right atrium, then the right atrium has to have a lower pressure. And it's usually, and that's called CVP. CVP. Central venous pressure. And it is referring to the pressure in the right atrium, which should be 0. Left ventricle generates a pressure of about 140. So we go from 140, and every vessel that we go through, the pressure drops and drops and drops and drops and drops until we get back to the right atrium, which is 0. That's your driving force. 140 to 0. That's a driving force of 140 millimeters of mercury, of driving force. Pressure force. Blood only flows from high pressure to low. That means from one chamber to the next in the heart, one vessel to the next in your vascular circuit. Good? I want you to send me a text when you start learning about that in physiology. And no, I can't be a guest lecturer. I get those requests all the time. Can you come and explain it to us?